I'd like to thank the organizing committee for giving me this opportunity. Without further ado, so my case, it's titled "It's Time Bomb," so it was a real time bomb for me. So it was a 64-year-old male patient, hypertensive, heavy smoker, and he had PCI to LED 5 years before presenting to us with 2 drug-eluting stents. Then he had suffered from crescendo angina, which was associated with dyspnea for 6 months. And his echo was showing normal LV dimensions with normal contractility and grade 1 diastolic dysfunction. So this was the first angio. We can see there is 2 stents, overlapping stents in the proximal LED with distal in-stent 3 stenosis. More or less it was significant. This patient has crescendo angina, and this was most probably the culprit, and he had an RCA that was receiving retrograde collaterals from the LED receptors. This was the RCA showing a short CTO segment with filling with autocollaterals ipsilaterally. And this is another view for the RCA. You can see the autocollaterals filling into the mid-segment of the RCA with a short CTO segment. So we did a balloon dilatation PCI to the LED. We didn't have drug-eluting balloon at that time, which I would have preferred and do IVUS guided, but it was not available. And this was the final result for the LED in-stent stenosis. And the RCA CTO would try with a fielded XCR couldn't cross. Gaia second crossed easily. It was a short one. And we exchanged, and with 2 overlapping stents for the RCA, I think it was a good accepted final result. This was the final result for the RCA. Was there any problem with this PCI or any comments that this RCA has a problem or the LED or? Yes, might step down, but for the overlap, nothing, right? Okay. So he was discharged on anti-ischemic treatment. He was asymptomatic for 3 months. Then he presented with chest pain, borderline blood pressure, even low blood pressure and sweating, and was in shock. So we thought this is in-stent problem, in-stent thrombus. We opted to picture the LED first, and it was totally fine. So we said, most probably there is a problem with the RCA, but we couldn't know what is the problem, and this was the RCA. Yes, it was a stent fracture, not at the site of the overlap, even in the second stent. And there was a pseudoaneurysm, huge pseudoaneurysm filling at the site of the fracture. And there was a hematoma also at the proximal part of the vessel, and most probably because of the shearing or I'm not sure, but I think not missing the ostium, but due to the fracture, hematoma happened also ostially or proximally. So any idea what can be done, or if you face this in the cath lab? So, okay. So we called the surgeon for this is the first thing you would do, because this patient may crash anytime. It's a fracture, pseudoaneurysm may rupture anytime. So this was our time bomb. So there was in the cath lab someone who saw that Stefan Renfrey, one of the CTO experts, did had a case like this before, where he tried to cross and to put a covered stent between the 2 stents, but this was very difficult for us to try to cross into this pseudoaneurysm and to manipulate our wire. But fortunately, with the C-on black that had multiple loops inside of this aneurysm, until finally which was guided by the microcatheter, we were able to introduce our wire into the distal part of the segment of the stent that was the distal one, after manipulating multiple times. We were trying to gain time until surgeon are ready, and we thought we can try. So we have the wire crossing and the micro, but we have a big loop. So by doing some tensing on the wire and not doing anything except retracting our guide to try to to make this loop, to make it straight. Very, very slowly, because if we lose the position of this wire, I think we would have failed. So trying to tense the wire and retracting our microcatheter, our only hope that this loop would straighten, and fortunately, at the end, it got straightened up. When this loop of the micro and the wire straighten, they straighten also the two segments of the fractured segments of the proximal and the distal parts of the stents. And this was the most important part, but the next important, you need to have a very good support. You need an extension, guide extension, because if you couldn't cross a stent or a balloon, then all of this would be futile. So by using a guide extension, we crossed the balloon, we dilated the segment, we were able to cross finally a covered stent. It was a 3.0 and we dilated with 3.5, and we had still the hematoma proximally. We put another covered stent, and this is our final result. Patient was stabilized, was transferred back to the CCU, and 48 hours later he was be discharged. So CHIP PCI, CTO PCI, sometimes some only option for some patients. You can use CTO PCI to do complications and to be able to manage these catastrophic complications. Like this one, they do happen. Sometimes they can be unpredictable. You need to be prepared and to be patient. Thank you so much.